Hi, I'm Dr. Brian Kaufman, a retired family doctor and a CLL patient myself, and the co-founder, executive vice president, and chief medical officer of the nonprofit CLL Society. Can you introduce yourself, please?
Yes, hi, I'm Tam, a professor of hematology at Monash University and the head of the lymphoma and CLL service at the Alfred Hospital in Melbourne,
In,
Australia.
Me- in Melbourne, Australia. So we're talking on different days, actually. And we're going to talk about a paper from ASH, the American Society of Hematology's major meeting that you are one of the lead investigators on, and it's a huge trial that you updated. It's the Captivate trial. So we've talked about that before, but can you remind the patients in a patient-friendly way what the Captivate trial was and why it was so important?
So the Captivate study was really the first major study in CLL combining Ibrutinib and Venetoclax. So it's a study in younger patients less than 70, and all the patients received the combination of Ibrutinib plus Venetoclax. The cohort that we're talking about, patients took the combination for 15 months and then they stopped everything at the end of treatment. So really the first study to really show a fixed duration, double targeted therapy in CLL.
And it's an all oral therapy and has led to the approval of ibrutinib and venetoclax in almost every country around the world, with the exception of the United States and Ireland, from what I understand. So you showed, and I think it's now, correct me if I'm wrong, 5.5 years of data, and you looked at some subgroups and some stuff and learned some things about what was important. So can you share what some of your, what I think this is called ad hoc analysis, looking at the data kind of after the fact and pulling out what you can learn from it?
Sure. So, I mean, it's always when we have a big clinical trial with long follow-up, so 5.5 years of median follow-up now, it allows us to really answer some important questions. And one of the questions was, in the age of modern therapy, does the size of your baseline lymph node matter? And whether if you have residual lymph nodes at the end of treatment, does it really matter? So we divided our patients into those who have got very big lymph nodes, bigger than 5 centimeters, and those who have got not very big lymph nodes, less than 5 centimeters. So we call them bulky versus non-bulky. And when we gave these patients ibrutinib plus venetoclax, we noticed that the responses are just as good for patients who have got bulky lymph nodes compared to those who have non-bulky lymph nodes, with the exception that the patients who've got the bulky lymph nodes often don't shrink the lymph nodes back to a normal size at the end of treatment, which is not surprising because if you start with 10 centimeter lymph node, it's quite a big ask for it to return back to less than 1.5 centimeters. And presumably most of the residual stuff that's left over is due to scarring. So we showed that.
I'm going to interrupt you for 1 second, but Dr. Jeff Sharman talked about the analogy: if you blow up a balloon and it gets enormous and then let the air out, the balloon never goes back to the same size again. So if you've stretched a lymph node out, there's scar tissue and stuff. It just never gets back to the same small size, or often it doesn't. Yeah. Sorry to interrupt you. Please go ahead.
Yeah, no, absolutely correct. So what we saw was that if we start off with enormous lymph nodes, then you will probably often end up with a small lymph node that is just above the cutoff for what we would call a complete remission. But those patients, if we test them by minimal residual disease testing, which is a way to look for a tiny population of cells in the blood or in the bone marrow, they will be negative for leukemia in the blood or bone marrow, meaning that we think those lymph nodes are probably just scarring. And one thing that what we did then was when we say, well, if you have a residual lymph node that is just above normal size, how does it compare with people who have got residual lymph nodes in the normal size range? And we show that provided that you are negative for minimal residual disease testing in the blood, that the size of your residual lymph node does not matter. And I think that's an important observation because it really tells us that CT scans are probably a thing of the past in CLL treatment. Patients getting ibrutinib venetoclax treatment. It just tells us that you often will have residual lymph nodes of no meaning whatsoever because it doesn't change how long people stay in remission for, or how long people stay, the leukemia stays away for. And that's in this day and age, the old system where we assign a response, because these people were called a partial response in the past. The old system where we assign a response based on just the size of the lymph glands on CT scan is really a thing of the past. And what's important is achieving a negative minimal residual disease status.
I'm very excited about this, and I hope it finds its way into clinical trial design and eventually into the community, because I think imaging is often overused in the community outside of academic centers, and I think it's often bluntly overused in clinical trials. So I think this is very important research and kind of very reassuring research as the technology advances. Are there any final thoughts or anything about this trial that you'd want to tell patients?
Oh, I mean, I think that the trial, unfortunately, the trial has wrapped up. So at the moment, we are inviting the main doctors who participate in the trial to continue to follow up the patients in a friendly consortium, because we want to know what happens to these patients when they later relapse and whether they respond to subsequent lines of therapy. This is a really landmark group of patients that we want to continue to follow up. So if you are a patient in the trial, please continue to see your doctor. Please encourage your doctor to share your information, because we're trying to understand what happens to the long-term, 10, 20-year history of these patients who start with Ibrutinib-Venetoclax.
Well, very exciting. All oral therapy. There were several other all oral therapies and other combinations presented at ASH that we're going to be presenting on the CLL Society website. So thank you, Dr. Tam, for your clear explanation of what's important and the learning points from this. Thanks so much.
Thank you.